Hello friends, so in this video we will learn the concept of odds and risk. In the risk we will understand the risk ratio, the relative risk reduction, the absolute risk reduction or the risk difference and the number needed to treat. In the odds we will see the odds ratio and the odds reduction. We will also understand the interpretation of these measures, the merits and demerits of these measures, and why do we need so many epidemiological measures. So what we see here is a pizza which has been divided into 4 parts. Now one part is there to be eaten. The odds of eating the pizza are the slices up there for eating divided by the remaining numbers of slices. So it will be equal to 1 divided by 3, which for a statistician would be 0.33 and which we normally understand as 33%. Now if we talk in terms of risks, the risk of eating the pizza is the number of slices up there for eating divided by the whole pizza. This would come out to be 1 divided by 4, which is equal to 0.25 or 25%. So in terms of odds, it turns out to be 0.33, whereas in terms of risks, it turns out to be 0.25. Let us have a look at this example. A group of 12 people underwent vaccination against a particular disease, let's say COVID. Another group of 12 people did not receive this vaccination. Now over a period of time, these two groups of patients were evaluated for development of disease. In the vaccinated group, 5 people developed the disease, whereas in the unvaccinated group, 9 people developed disease. So now we need to see whether this difference is significant or not. This is the usual 2 by 2 table that we see in statistics. On the top, this is the variable 1, which means the exposure. In this particular scenario, the exposed group is the one which has been exposed to a vaccine, and on the other right side you have non-exposed group. Now you see on the left side the variable 2 represents the outcome, whether it is present or absent. In our example, the presence of disease is the outcome. Now let's fill the table on the exposed side. The total number will turn out to be 12. The number of people who developed disease is 5 and the number of people who did not develop the disease is 7. On the non-exposed side, the total number of people was 12 and the number of people who developed the disease was 9 and the number of people who did not develop the disease was 3. So in the exposed group, outcome is present in 5 and absent in 7. And the total number of people in this group is 12. In the non-exposed group, the number of people developing the disease is 9 and those not developing the disease is 3 and the total number is 12. So this is the standard table that we have when we calculate the risks. The risk of outcome is in the exposed group is the ratio of the number of people in the exposed group who developed the disease divided by the total number of people there were. Similar to the example that we had seen, the slice of the pizza divided by the whole pizza. In this particular case, the risk of outcome is in exposed is A divided by the sum of A and C. And the risk of outcome in non-exposed will be B divided by the sum of B and D. Now if you have to look at the risk ratio, it will be the risk of developing this outcome in the exposed divided by the risk of developing this outcome in the non-exposed. The formula turns out to be A divided by the sum of A and C, and this whole is divided by B divided by the sum of B and D. In the scenario that we have earlier discussed, the risk of outcome in exposed would be 5 divided by the total number of patients, that is 12, and the risk of outcome in non-exposed will be 9 divided by 12, that is the total number of patients in that group. And the risk ratio will be the risk of this outcome in exposed divided by the risk of the outcomes in the control group, and that will turn out to be 5 divided by 9, which is 0.55. Let's look at another example in this particular table. We can see in the intervention group the number of deaths was 20 and those who survived was 80 with the total number of 100 patients. On the control sides, the number of deaths were 25 and 75 people survived and the total number of patients in this group was 100. the risk of death in the treatment group would be 20 divided by the total number of patients that are there, which is 100. It turns out to be 0.20. Now the risk of death in the control group is 25 divided by the total number of patients, that is 100. So this comes out to be equal to 0.25. If you look at the relative risk or the risk ratio, it will be the risk in the treatment group divided by the risk in the control group, which would be 20 divided by 25, which is 0.80, which is 80%. So what do you understand by the statement relative risk or the risk ratio? It means that the risk of dying in the intervention arm is 80% of the risk of dying in the control arm. In other words, for every 100 deaths in the control arm, there would be 80 deaths in intervention arm. Relative risk has its merits. It's applicable to all kind of patients. It is easier to interpret than odds ratio, but then it has its demerits also. An important demerit is asymmetry, and in the case that we have just discussed, the relative risk was 0.8. The relative risk reduction was 20%. Now if you look at the relative risk of survival, it was 1.06, and the relative risk of increased survival is 6%. This 20 and 6 describes the asymmetry. Furthermore, relative risk lacks neutrality. The term risk sounds fit only for unfavorable outcomes. For example, if somebody says the risk of survival, it doesn't seem right. Another demerit is it cannot calculate confidence interval if there are 0 events in both the treatment groups. Now let's have a look at odds ratio. It is commonly used in betting. The same table that we have just seen, the odds of death in the treatment group is 20 divided by the remaining participants, which is 80 and not 100 as we had seen in relative risk. So the odds of death in the treatment group would be 20 divided by 80, which is 0.25 or 25%. The interpretation of this is that in the intervention arm, the chances of dying are 25% of the chances of not dying. The odds of death in the control group in the similar way is 25 divided by 75, which turns out to be 0.33, that is 33%. And what it means is that in the control arm, the chances of dying are 33% of the chances of not dying. Now if you look at the odds ratio, it is A divided by C, and this whole is divided by B divided by D, which actually means A multiplied by D divided by C multiplied by B. If you look at this table, you can see cross multiplication happening, and so that's why odds ratio is also called cross product ratio. So the cross product ratio in this particular table is odds in the treatment group divided by the odds in the control group, that is 1 upon 4 divided by 1 upon 3, which is equal to 0.75 or 75%. This ratio of 75% means that the odds of dying in the intervention arm are 75% of the odds of dying in the control arm. The odds ratio also has its merits. It is applicable to all kind of patients. It's not a loaded concept. It's neutral. So the odds of dying or the odds of surviving both mean the same. This is symmetry. It can be used in adjusted analysis using logistic regressions, whereas risk ratios cannot be. It's a favorite measure for meta-analysis. The odds ratio obviates the need for a prospective study, but it also has its demerits. It is a difficult concept to understand and interpret, as most of the people are used to the concept of percentages, and if we interpret it like relative risk, it will be overestimated. As you have just seen in the example above, in that same pizza, the odds were 33%, whereas the risk was 25%. So if you interpret odds ratio as a relative risk, you will be overestimating it. Now let's have a word about odds versus risk ratio. We see here that the odds ratio is for use in prospective studies where you have an exposure which is defined, and after that you look for outcome. So this kind of a study can only be done in a prospective way. So the risk ratio can be calculated only in prospective studies. The odds ratio, on the other hand, can be calculated in retrospective studies as well as case control studies. Both these calculate the magnitude of risk or association. The odds reduction is 1 minus the odds ratio, which is 1 minus 0.75 in our case, and it comes out to be 0.25, that is 25%. So what does this odds reduction mean? It means the odds of dying in intervention arm has been brought down by 25% compared to the control arm. And as we had just seen, a relative risk reduction can be calculated by 1 minus the relative risk, which is 1 minus 0.80, or you can say 100 minus 80, which is equal to 20%. And what relative risk reduction means is that the risk of dying in the intervention arm has been brought down by 20% compared to the control arm. Absolute risk reduction, or the risk difference, is the rate of death in treatment group minus death rate in control group, which is 20 minus 25, which is equal to minus 5%. The interpretation of absolute risk reduction or risk difference is that there is 5% less risk of dying in the intervention arm compared to the control arm. Now let's look at the interpretation of the risk difference or the risk ratio. If the new treatment has no effect, the risk of mortality in both groups will be the same. So the difference will be 0, while the ratio will be 1. If the new treatment decreases the risk of death, then the difference will be negative and the ratio will be less than 1. If the new treatment increases the risk of death, then the difference will be positive, while the ratio will be more than 1. The absolute risk reduction has its merits. It's easy to calculate. You simply have to subtract, and it is easy to interpret also. It is symmetrical. It conveys the same effect for favorable as well as unfavorable outcomes. This helps calculate the number needed to treat. The confidence interval can be calculated even when no patient had outcome of interest in any group. The absolute risk reduction or the risk difference has its demerits also. Sometimes it is too small. Moreover, it cannot be applied equally to all types of patients. The number needed to treat can be derived with this formula, which is 1 divided by the absolute risk reduction. So in this particular scenario, it is 1 divided by 5%, which is 100 divided by 5, which is 20. So the number needed to treat of 20 means that for every 20 patients that we treat in the intervention arm, compared to the similar number treated with control arm, 1 extra patient will survive in the intervention arm. So the word is 1 extra. So when you are using this number needed to treat or the NNT, you must specify the follow-up period over which this difference has been observed, and you must also specify any unfavorable outcomes which may have happened. Now the question that comes up is, how much number needed to treat is good? Actually, there are no magical figures. If you are looking at an inexpensive drug with no side effects, a higher NNT can be taken. NNT of 100 to 200 can be taken in this scenario. Now, if you are considering it for a risky surgery, an NNT of only 20 should be considered. There is a difference when you are looking at prophylactic versus active treatment for calculating an NNT. For active treatment, an NNT of 20 to 25 can be taken, but for preventive treatment, a higher NNT should be taken, which around 250 to 500. The numbers needed to treat also has its merits. It gives a quick idea of cost effectiveness, which is easily understood by policymakers and physicians. The demerits, it is not easily understood by patients. For example, if you tell a patient that for every 4 patients that we treat in the control arm, I'll be able to treat 1 extra patient in the intervention arm, the patient may simply ask, do I belong to those 4 patients or to that 1 patient who survives? Sometimes when the treatment is harmful, the risk is increased. So the number needed to treat in such cases will indicate the number needed to cause 1 extra harm. Now this is sometimes called the numbers needed to harm. Why do we have so many epidemiological measures? One reason is different epidemiological measures appeal to different constituencies and clients. Now different people look at results for different purposes and in different ways. For example, a hospital administrator looks at cost effectiveness, while a physician looks at the benefit to the patient. Now the question comes up is, what should be an effective epidemiological measure? An effective epidemiological measure should be easy to understand. It should give an idea of cost effectiveness. It should be meaningfully applicable to all kinds of patients and should convey same idea whether you use it for unfavorable or favorable measures. Thank you so much for watching this video.